Welcome to tonight's Queer Table Talk. My name is Dominic Green. I use he, him, his pronouns and am the Director of Programs and Faculty at Inclusive Communities. Before we start tonight's event, I would like to acknowledge the traditional homelands of the Native and Indigenous people who live and took care of the land that most of us gather on tonight. They belong to the Omaha, Ponca, Pawnee, Oda, Missouri, Sante Dakota Sioux, Kansas, Iowa, Cheyenne, and Winnebago people. We honor with gratitude and pay our respects to all Native and Indigenous people. Omaha Table Talks, as we refer to them as OTTs, was initially recreated in Omaha in 2003 by the Social Justice Advisory Committee of Catholic Charities Omaha. And in 2012, Inclusive Communities acquired OTTs and shifted to a larger public discussions over comfort food. A few years ago, we partnered with OutNebraska and Abby and her team to create a quarterly series called Queer Table Talks, or QTTs. And we greatly appreciate that partnership with OutNebraska to hold conversations that are focused around the LGBTQIA2S+ community. Due to COVID-19, we have shifted holding these events over Zoom, and welcome you to have your own snacks or foods or beverages with you as we have these discussions tonight. We are looking forward to a time when we can come together in public, but also are working on a way to have these events be hybrid as well for folks who still would like that virtual option. And now I'm going to toss it over to Colin, who's going to introduce a couple of housekeeping agreements for us. Colin.
If I can find my mute button, thanks, Dominic. I appreciate it. Hi, everybody. My name's Colin McGrew. I use he, him, his pronouns. I'm a senior programming partner here at Inclusive Communities. Just a couple of things that I wanted to mention for you all. The main session of this conversation will be recorded, but when we do move into breakout rooms a little bit later after the panel, those will not be recorded. But when we do come back to this main session for some share outs, that again will be recorded. So just keep that in mind in terms of camera and share outs too as well, just knowing that. I would also like to acknowledge the facilitators that we have here that will be acting as those guides in those breakout rooms. So thank you all for joining us and volunteering your time to do so. We also have ASL and Spanish interpretation. New this year, we've partnered with World Speaks to provide simultaneous Spanish language interpretation. If you need either ASL interpretation or Spanish interpretation in those breakout rooms, please let me know, and I will make sure that the correct interpreter is in that room with you. A few tips just in general when we're using these interpretive services. If you could just speak clearly, take some pauses, and keep a consistent pace when sharing out, that just helps to make sure that our interpreters are catching everything that you're saying and translating it in an accurate way. We've also enabled our auto closed captioning as well. So if you do want to utilize that service, there should be a button available for you to press in your toolbar. That same toolbar will also have the ability for you to transition in and out of that Spanish interpretation channel. Other than that, Dom, did you want to share some of those virtual agreements that we have? That slide. Perfect. I can just name a couple that I remember off the top of my head. The first is that we invite folks to change their name to include their pronouns. So to change your display name, just go ahead and right click on your photo and you'll be able to do that. Another one is that we just invite people to stay on mute unless actively speaking. That way we can just minimize all the background noise that happens otherwise. I've mentioned the recording. Feel free to utilize the chat or any of kind of the reaction features that Zoom has. It's always a fun way to interact with the panel, and then also to share out resources in the chat as well, which we'll collect and send in kind of a follow-up email. Finally, when it does come time for the breakout rooms, I will be the one that will place you in those and bring you automatically back. So you won't have to worry about really doing anything for that. We'll also keep a timer for you as well. I think I am done talking, so I will go ahead and throw this to our moderator of the evening, which is Abby Swatsworth. Hello, Abby.
Hello, Colin, and hello, everyone who's joined us this evening. We're really pleased to have people come to hear this important conversation. As Dominic mentioned, we had partnered with Inclusive Communities. We feel it's important for people to hear the lived experience of LGBTQIA2S+ or queer Nebraskans. And I claim the word queer as my identity. I want to recognize that sometimes that's a difficult word for elders in our community, but we've found that we chose it as our language for the talks because in some ways it's an umbrella term that can cover our whole community. So tonight we are talking about healthcare disparities and healthcare access for the queer community. And we're going to start out with a question that allows each of our panelists to introduce themselves a little bit and tell us about the work that they do. So I think we'll get started with Dr. Gina Amoura. And our first question that everyone will answer is, what work are you engaged in with regard to health disparities and healthcare in the LGBTQIA2S+ community?
Thank you, Abby, and thank you to the group for inviting me and for all of you for being here tonight. Yeah, my name is Jean Amoura, and I am an Omaha native and work at UNMC in Nebraska Medicine. I'm a physician trained originally in OBGYN as a specialty in medicine. But my work over about the past 10 to 15 years has focused increasingly on transgender medicine. And so I was starting to see patients, again, probably maybe starting about 15 years ago, people needing these services and were coming to see me because they couldn't find other providers who were able or willing to provide that care, and so was kind of self-taught, essentially, back in the early days of this, and continued to see more and more patients, and starting in 2016, developed the first transgender care clinic in the area, and we still have that going on today. So it's our gender care clinic that's multidisciplinary, and I'm the director for that. In that, my role there is in providing direct health services to patients of all gender identities and truly of all ages, although primarily I'm seeing folks from adolescents upward, but occasionally consulting with families even of younger children if they have questions or just want resources or guidance. So that's the role that I play.
Terrific. Let's popcorn over to Jay.
Good evening, everybody. My name is Jay Irwin. I use he, him, and they, them pronouns, and I am a faculty member at UNO. And my real involvement with health disparities is from the research side and a little bit of policy advocacy side. So I'm a medical sociologist by training, which means that I study health disparities, and the health disparities that I study are LGBTQ related health disparities. So most of my research, I've been engaged in research on lesbians in the Southeast in the United States. That was my dissertation. And then when I moved up to Nebraska in 2009, started getting engaged with LGBTQ research locally. So I work with MSHRC, the Midland Sexual Health Research Collaborative, which is housed out of UNO. And we have done now 2 statewide surveys of LGBTQ folks. And I also do work with Dr. Amoura with kind of the work that's being done in Nebraska medicine. also do a lot of kind of educational presentations for med students, for nursing students, those kinds of things. I teach an LGBTQ health class at UNO and the like. So thanks. I'm glad to be with y'all tonight.
Pastor Daryl.
Good evening, everybody. My name is Pastor Daryl Brown Jr. I am the founding senior pastor of Kingdom Builders Christian Center here in Omaha, Nebraska, as well as the manager of African American and Latinx education at Planned Parenthood. My work is kind of at the intersection of spirituality and healing, Black liberation, as well as LGBTQ plus identities. Also am someone that identifies as someone that is living with HIV as well. And so I bring all of that to this work with me as well.
And that leaves Courtney. Thank you.
I'm Courtney Yoachim. I'm a professional counselor at Kindred Psychology. I've been here for about 2 years now. And I, like when I started out doing therapy, that was one thing that I was starting to run into, was a lot of like queer identities as well as my own. And so kind of quickly took that up and just wanted to continue doing that. And then here at Kindred, that's a big thing that we focus on, is trying to be an open space for like a lot of queer and marginalized identities in general. So I've really developed a passion for it. And so I would say a lot of people that I see have a lot of different kinds of queer identities.
Terrific. So I really feel like we've got a very esteemed panel with a lot of experience with mental health and research and direct care and HIV and education through Planned Parenthood. And so really looking forward to learning from y'all tonight. One of the questions that we sort of came up with, because we thought maybe some people wouldn't know, would be questions about some of the biggest barriers for queer people in accessing care. And what can you tell us about barriers that you see? Courtney, I think we'll start with you this time.
Yeah, I mean, I think like as far as what I see in the mental health world, I think definitely the biggest like barrier for everybody is always going to be money and insurance. And that's a lot of people, I think, especially trans identities, queer identities, or different like racial or other marginalized identities, because our insurance companies are tied to things like having a career, or if you happen to be married, and because there are a lot of different identities where those things are going to vary, there's not always a guarantee that people have the access. And I think without insurance, most people aren't going to be able to afford the care that they need.
Do you think stigma in regards to mental health also poses a barrier for queer folk?
Definitely. I think there's that intersectionality that always comes in. We talk about queer identities, but there's always going to be the intersection with that, with gender, with race, with everything. And I think like specific intersections, it's hard to openly talk about different things like mental health, or openly say like, I need help. And then even if you do, going to a professional and you don't know necessarily how educated that therapist is on your specific identities. And so I've had quite a few experiences with people who have talked with previous professionals who have, you know, said things or led them in a direction that didn't quite fit for them. And so it's hard to feel in those settings that you have the power to advocate for yourself. And so it can sometimes turn people away from care.
I would say in addition to like money and insurance, I would also say that, and I'm specifically speaking to sexual health and reproductive health services, I would say that also medical mistrust is a big piece as well. Like Courtney mentioned, there are a lot of negative experiences that LGBTQ plus folks have experienced with regard to care. That really ties also into stigma that we experience with healthcare providers as well. there's a ton of stigma that can even show up in medical practitioners that affects people's willingness to want to go and be seen and be tested and things of that sort. And so there's this thought of, oh my gosh, I'm going to be judged. There's this thought of, are they really going to do what they said they're going to do and only that, or are they trying to coerce me into something different? What does that look like? And I think that those pieces are also some barriers as well. In addition to also a lack of cultural sensitivity and awareness and things of that sort that we just, it feels different when you feel like you can go into a place and a space and feel like you can connect with those that are providing services to you. And when there is no level of connection, when none of the art on the walls looks like you, or none of the paperwork seems to be tailored to your needs and your lived experience, that really can deter people from going and seeking care.
Yeah, Abby, I'll piggyback off of Daryl if that's okay. And just say, I think one of the things that also in combination with a lack of cultural knowledge about LGBTQ plus communities is just a lack of provider training. Medical school or, social work and counseling, maybe in the mental health fields, has potentially a little bit more coverage, but there's just not a lot of coverage of LGBTQ plus identities and healthcare needs within the very busy schedule that med school has for providers. But what that means is that providers are out there often not knowing what they don't know. And so how do we make sure that, we've got providers who are knowledgeable, and if we're not requiring any kind of coverage of LGBTQ folks in curriculum, how do they learn those things? And some providers are really good and they'll go and they'll learn on their own, but that's up to them to do that. And often providers are very busy and they don't have the time or even the knowledge to know where to go to get those resources sometimes. So that's what I see from my seat on the bus of, there's a lot of education that LGBTQ folks do for their healthcare providers. Which is an unnecessary burden to put on someone who is there seeking healthcare.
Yeah, I'll keep going. This has been part of my mission, in addition to caring for the patients, is recognizing that people need knowledge in their providers at all different levels. And the beautiful thing is, and Jay, as he already mentioned, has certainly helped me in teaching med students, and I think has helped in a variety of different places at our med school and our health profession schools. But the students, the really heartwarming thing is that I feel like by and large that the students are unbelievably on board and engaged and want to do better and be better. And I'm incredibly hopeful about the next generation of providers as they come along, but that still doesn't, provide the immediate benefit that people need who are needing healthcare right now. It's so, even as we do our best to try to cultivate this in folks, and they are thirsty for the information and they want to be great doctors, and they understand that, and great healthcare providers in general, and they understand that this is part of it, and learning about communities that maybe they have not had direct contact with, or have not in a provider patient kind of situation, and what's okay to ask and what's not okay, and how to get at these things. Honestly, if I see anything, it's that people are almost overly concerned about offending and that kind of stuff, and they get kind of very tense and hesitant about just doing their job and providing great care for people. So anyway, I think there's a lot to be hopeful for in that. But in the immediate term, I mean, I agree. As far as barriers go, it is surprisingly, I feel like in this day and age, it's surprising how tricky it is. People that have come to see me have already found me. But even when we look at the other kinds of services that they might need that are different from what I'm doing, they need a dermatologist, or they need various other parts of their care, maybe related to transition, maybe totally unrelated. They just need a cardiologist or what have you. And that it ends up requiring a lot of kind of what we would call a warm handoff of, I'm actually going to do the legwork to the extent that I can to make sure that the clinic that I'm referring you to, if I don't know these people directly, are going to be able to take care of you well, not just the medical part, because I know that the medical care is going to shut down if you're not seen as a human being when you walk in the door, and the front desk doesn't understand that this is the name that you're using and these are the pronouns you're using, and it's just not negotiable, and you don't want to have that discussion. You're there to talk about your cholesterol med or whatever. You know, the relevant thing is you're not there to teach everybody about what it is to be transgender and all that. So, but it is, can I think feel like a very scary place for a lot of people every single time they're going to another provider, another specialist, this or that. It can be a real burden for folks. I feel like overall it's getting a lot better, but there still is that personal trauma for a lot of people, and just really kind of the community trauma that everybody knows that people have had some pretty horrific experiences, and it's not all, you know, just ancient history. It still goes on.
That's true, it does. As a statewide organization, we sometimes hear from folks who live in greater Nebraska about the struggles that they have accessing care, where often for transgender and gender expansive folks, they're only seen for their identity status. And so sometimes, like, doctors in rural areas will say, I don't know how to treat you, when it's, you know, a broken arm or a bronchitis or an ear infection, right? Which has nothing to do with someone's identity. So yeah, we do hear that, that it's still ongoing. And that's why I think all of your work to sort of uplift this conversation and the education that you're doing is really important. So that sort of leads into the third question I had, which is, can we talk about some of the ways that the queer community has come together to overcome disparities and barriers? And Courtney, I think you had a great book that you were looking at, and some things you wanted to share. So let's start with you.
Yeah, well, I mean, the book that it was on my reading list, and then this panel came up, and so I went ahead and read it over the weekend. It's called The Care We Dream Of by Zena Sharman, and it is an entire book that talks about the queer community and health disparities, but it also takes a very intersectional approach to it. And so it obviously recognizes that if you are a queer person, you probably have other identities tied into that. And if you've experienced health disparities, you've probably experienced disparities in a lot of other parts of your life too, that it's not like a narrow thing. But something that they were recognizing in there that I think is really important to remember is just that the queer community, and I think marginalized communities generally, have always relied on each other, knowing that the systems in our world aren't necessarily created for us. And so we have mutual aid, we have each other. And I think that that's definitely something, like sharing resources. I think something that Dr. Amoura was saying, that, you know, they've already found her, but where do I find a dermatologist? Where do I find, and something that I have to help people try to find is like, how do I find a hairstylist? that I can go to that I know is going to be totally cool with not just giving me a short haircut, but giving me like the short masculine haircut that I'm looking for, or whatever the case is. And so it's that mutual aid of relying on each other that, yeah, I know a lot of great places now, but not every healthcare provider is always going to have all of those things. And so the queer community, we have to rely on each other for a lot of that.
Jay, is there anything in your research that sort of points to the way that communities come together?
Oh, good question. There's not, only because I do boring surveys. I love a survey, but they're not like, they don't really speak to that kind of question very well. But piggybacking off of what Courtney was saying, I mean, the amount of just crowdsourcing referrals for care that I see on social media points to the need for, I mean, since I moved to Nebraska, it's been 12-ish years now. Jean and I are also involved in this group called Ptrn, Professional Transgender Resource Network. It's an organization that works to advocate, to educate providers who are providing care in trans spaces. And one of the things that's been really frustrating through that work is that we initially wanted to publish a list of providers, but there's enough providers who are concerned about either their other patients, their environment that they work in, and having their name on a list of LGBTQ plus providers sounded too worrisome for them to put their name down in a public facing kind of way. So again, like relying on who you know and who can help you navigate those systems. It's great that we have that, but it's a shame that we have to resort to just, do you know enough people who can provide you the name of a good provider?
Right. I'm going to jump into, I totally agree. I feel like it's another of these things of putting a lot of burden actually on the community to have this kind of underground railroad, effect of trying to source their own providers. And it's really a shame. I mean, I will tell you, we've gone to great lengths in the clinic to try to collate and coordinate resources, healthcare providers. We even did a survey actually of just kind of not even a survey, but just a quick sort of questionnaire within the clinic of tell us about hairstylists or people that do electrolysis or gyms that you go to, shops that you buy clothes in, just anything that you might recommend. Because I would recognize how often that people would come in and they were new to the area, or they were young, or whatever it was. They didn't have this as broad a network, and they wanted to know these simple things about where to find certain services that were safe. And I would sit there and think, I don't know the answer to that, but I've seen 3 people already today that could have answered that. If I could just get you all together. So we tried to do that. One of the interesting things is that one of the things I get asked about most often by not just my patients, but by other providers and other groups and organizations just around the community is, can we have a list of primary care providers? Can we have a list of mental health providers? And the problem that I've got is that we've got a pretty kind of short list, in my opinion, a too short list already. And those people's schedules get filled very quickly. And so it's kind of like, the problem is just that we need more and more and more. And so, yeah, these are the kinds of resources that are in such high demand, and it's just not. So I end up kind of reserving those back for people that we're actually seeing, because you know, it's a very precious sort of resource, and it shouldn't be that way. You know, it can be frustrating. Just that we need more people that have at least just basic training. I mean, I think for lots of folks, they're just LGBT identified and they want a provider that is affirming to treat them, to work with them for their depression and anxiety. They don't actually need somebody that is an expert on gender studies or what have you. I mean, it's they just need to know that it's going to be a safe space to go to. And I think a lot of times for the providers, they just don't feel like they've got all the skills up to speed or what have you to kind of put themselves out there in that way.
Daryl, what would you like to add in terms of this
I would
question? Everybody brought up.
Sure, I would definitely, as my dog tries to steal the show, I would definitely piggyback off of all of the answers and just again reiterate that really and honestly, we are our own rescue, unfortunately. And depending on what the resource is, traditionally our community has just pulled together and pooled resources and those connections together amongst ourselves. And in the instances where we've had to look outside of our own communities, I think that relying on a list such as what Dr. Amoura has mentioned has been super helpful. I can speak to that as someone living with HIV. It has been an interesting intersection of identities to try to find a safe space for, because again, finding someone that can provide the mental health services necessary, that is LGBTQ plus friendly, that is HIV, that is aware of HIV facts and data and that lived experience, that also understands the intersectionality of adding race to the mix of that. And so that does get difficult. And so in a lot of instances, we end up relying on our own folks, if you will. I often tell people that it's so important to find your own tribe because it is a means of survival in many ways. And so finding our own tribe, but then also having those conversations with one another to find out who are those individuals outside of our community, who are those allies that we can lean on for those services and that care as well.
Oh, Abby, you're muted. We can't hear you.
Thank you. I do that at least once every meeting. It's not a meeting if I haven't, stayed muted. There was a question in the chat, and I don't know if we'll have time to get to it, but it could be an entire queer table talk. And I think that's actually a great topic for us to think about, but related to spiritual resources in the community. So Daryl, if there's anything you can drop in the chat as we try to answer that question, that would be great. And we have one final question about healthcare, and that is, how can community members help in creating affirming care and affirming services? Are there ways that allies can be involved? And Jay, why don't you start?
Sure. I think one of the ways, especially if you're an ally, would be to advocate for simple changes within a clinic that you're going to. So if you are going to a clinic and you notice that their forms could be more inclusive, mention that, edit their forms for them, write on them, give them feedback about how to do it better. Because, I think especially if you're an ally, it doesn't feel the same as if you are advocating on behalf of yourself. And there's a bigger fear, and it's just kind of intimidating to, go up to a clinic staff and be like, hey, you've left me out specifically, instead of, hey, have you thought about, you might have unintentionally left some folks out by the way that you've asked these questions. Thinking through ways that you can do just small level advocacy. It doesn't have to be big. It doesn't have to be showy. It doesn't have to, you don't have to go down to the unicameral and, you know, sit in the hot seat. You really can do small steps in the spaces that you're already in.
That's terrific. And I think before we go to other panelists, it's I just noticed the time. And so we're going to go to Dominic and talk about our breakout rooms.
Hello. Thanks for that, Abby. And we will make sure that you hear from the other panelists on that question after we come back from breakout rooms, because that is important to do as well. But we do want to take a chance at this time to go into those breakout rooms. I'm going to ask that Colin go ahead and send us to our breakout rooms, and we'll see you in about 20 minutes. We are going to allow for the rest of the panel to answer the last question that Abby posed, and then we'll get to our share outs from you all and hear what you all were discussing in your tables.
Great. Thanks, Dominic. Just to refresh folks on the question, it's sort of a call to action in a way. We were asking, how can community members help in creating affirming care and provision? And Daryl, why don't we go ahead and go to you?
I think one of the biggest things is definitely be responsible for your own education. Do your best to, if you're truly going to be an ally, dig into the data for yourself, dig into the information for yourself, and engage in conversation with people, ask questions. But additionally, I mean, that's kind of on a higher level, but I would also say to also nip stigma in the bud on a personal level. I think that we often talk about these things from such a high level conversation. We know the systemic stuff is going to be there. And if we just be honest, sorry, disclaimer, the preacher has a potty mouth. The shit's not going to change, okay? Some of it's just not going to change. And so we really have to be adamant about trying to change this on a one-on-one level in some instances. Saying something back to the family member that's making homophobic remarks, saying something back to the family member that is increasing HIV stigma, or just increasing stigma around sexual health in general, or any of these health disparities that we may be referring to as relates to LGBTQ plus identities. So those are just a couple of ways that come to mind for me.
Awesome, thank you. Courtney?
Yeah, I'll just kind of jump in with my therapist-y side of things and piggybacking off of the pastor side of things of, yeah, definitely doing all whatever feels right in the moment, whatever, meeting yourself where you're at, of if you feel that you have the energy and you have the extra effort to give, going out and advocating in the ways that you can. If that means, from what Jay said, for the breakout rooms, of advocating in different spaces, maybe it's even just your workplace of, I mean, changing bathroom signs to gender neutral is not a difficult task, or advocating at different doctors' offices to get those intake forms changed. But it also is completely understandable if for whatever reason you're not in a place to be that outwardly, have that outward energy for advocacy. And so then turn to what you can do. And maybe that's reading a book that opens you up to different perspectives, or maybe that's pushing yourself just to view more media with more broad diversity. Even as simple as, I have a friend who is trying to train themselves to use they, them pronouns only for every single person that they didn't know or that they had never met. So kind of using they, them as the default instead of what we normally do. And I'm like, that's such a simple thing, but it's going to change the way that you see things. And that's how we make bigger changes.
I love it. I'll jump in. The thing that I want to really, that I always encourage my patients to do, and just would encourage everybody on the call to do, is speaking from the standpoint of somebody who's working as a part of a very large organization that's providing healthcare. I think it's amazing how when you step into these situations, and lots of places can, I think, feel quite large and overwhelming. And I really try to empower either students or patients, even though they feel like they're the lowest person on the rung, on that ladder, but that actually the organization is designed to listen to, they are the like end user, and the organization is far more receptive to that voice than they might perceive. I mean, it's weird how you get into these huge organizations and everybody feels like they're a tiny little cog. I mean, I feel like that in my own place. And it's like, I'm working here as a physician and I'm a middle-aged person and I was a student here. Like we all feel kind of small. But when you're actually the person that the service is directed towards, so whether that's that you're a student in a college, in a university, or that you're the patient in the hospital, your voice is much louder than you might think. And so what I would encourage is for people to, like, again, when you're in a, encountering a larger organization, the person who's like at the front check-in desk may not have the power to change the forms. And so, you do want to try to think about, okay, I want to make my voice heard, but honestly, you get that patient satisfaction survey, go to town on it. You get, any chance that you get to speak to the organization more largely, go to town. And if it's about your own experience, or kind of as Jay was saying, I think often it's you feel much stronger when you are advocating on behalf of somebody else, and that is helpful too. But to say, I don't find the current state of affairs in your organization to be satisfactory or reasonable. If it's that I personally felt this or that, this was my experience, so that it might go to, in my case, a patient relations office. That is going to get seen by a lot of people. That is actually going to get a lot of attention. So that's where I always try to tell my patient, I think sometimes they feel like, well, I like you and I don't want to hurt, I don't want to, get you in trouble or something like that. And it's like, no. You are helping me to help you, because I can go up and I'm just one provider of many. And everybody thinks that the job that they do is the, most important or whatnot. It's a very different voice that I have. When it's a patient saying, this was my experience, or this is a problem, I just think organizations all over the place, including hospitals and healthcare organizations, are increasingly recognizing this is not a hard sell to the legal office in the hospital. They know we've got to get up to speed. So the only reason why I feel like it's moved so slowly is that people feel kind of like, is this group really as big as Amoura is really saying, or whatever? Like, is this really enough of a problem? So I would just encourage folks to recognize your power.
And I want to add to that from the mental health side of things too, that I think there's always going to be that natural power dynamic that forms when you have professional and client, but that, at least for me, and I know that any decent therapist is going to want feedback. And so because I know how limited it is, the number of mental health professionals who have very specified training in different things, because as we talked about earlier, there's just not enough of it. But there are a lot of therapists, I think, who want to be. And so give them the feedback. If they're saying something that is off, if they're saying something that is like, whoa, okay, I see the intention here, but not okay, give that back to them. And if it's bad enough, obviously get yourself a referral, get yourself somewhere else. But obviously you don't want to be doing harm, but yeah, everybody has to learn. And there's a lot, there's too many cultures to feel fully and completely educated on all of it. So don't be afraid to speak up in your therapy appointments, that you need to be able to be seen and heard and have that relationship be strong in order to do good work.
And if I could just add to that, that our healthcare providers work for us. They are working for us. And so we are empowered to make the decision that is going to be best for us. We still have bodily autonomy. We still have complete control over where and how we receive our care, and just standing by that, no matter what that power dynamic may seem like. The reality is at the end of the day, these medical professionals are here to work for us.
This is all really great. Thank you. Those felt like really complete answers. And Jay, I don't want to leave you out if there's like a last minute thought you wanted to add, but I do also want to hear what our breakout discussions were like. So Dominic.
Thank you, Abby. Yes. Wonderful conversation there. And we want to hear from you all because that's also part of what table talks are. So if I could have Monia or whoever is going to share out from Monia's group as to a couple of things that you all were talking about and discussing there.
Yeah, I can share, and anyone else in our group, if you want to add to what I share here, you can jump in. I'm Manya, I go by she, her. Within our group, we got through the first 3 questions on here and did discuss, like with the panel discussion, what stood out in there is just a lot of emotional reactions to how healthcare is served in the rural communities with one of the people in our particular group, and in the mental health space, and in the school education system as well. And then when we talked a little bit about emotions, it diverted just a little bit into us having, someone essentially bomb a group and had a little bit of space to discuss what the feelings were and what people's thoughts were about that in particular. And also after that portion went into the impact of creating an affirming community and just, getting healthcare resources and understanding, where there are people and how to get that information, in addition to kind of that underground portion that we talked in the panel discussion, and how it is beneficial to have equitable healthcare across the community, regardless of, what spaces that we all sit in, and how that benefits our community too.
Thank you for sharing. Our next share out is going to come from Audrey, I believe, is sharing out for Paulstrom.
Yeah, so we really were lucky in our group. We have a person who's currently in the healthcare field and pursuing advanced kind of certification at this time. And I just also know from looking to the audience that we have a few medical students who joined us tonight. And so kind of just talked about how encouraging that is, being part of the solution by participating in events like this, and the gratitude we feel for the presenters making time to, educate future healthcare providers and how that culture shift is coming. And we can all be a part of the solution. So I think it was a fairly encouraging conversation. We also just talked about some of the barriers that people have in sharing with doctors, and the fear of maybe not receiving appropriate care or being denied care. And so, what are some ways that practices can be improved in institutions so that there is this open environment communicated. We talked a little bit about forms and, adding pronouns and chosen name and that kind of thing. We also just talked about the emotions of, hearing. We're so hopeful that there's people doing good work in our community like Daryl and Dr. Amoura and Dr. Irwin and Courtney as well. And just having the diversity of healthcare providers from, mental health, spiritual health, physical health and how important that is. But also we all have a responsibility to kind of leverage our privilege to make things more equitable. And then we talked about the healthcare disparities too, just of, people of color, trans women of color having the worst outcomes, but also, sometimes that people feel that they have to justify or explain their existence, and educate the doctor and how that can in itself be a barrier, or feeling like maybe their pain or their experiences aren't recognized. And so someone had brought up Serena Williams, and although she's, a top tier athlete, she still had to advocate that something was wrong and wasn't heard. And what does that look like for someone with less privilege? So really, really great conversation. I wish we could have had it for longer.
Thank you so much for sharing out. And we have about 10 minutes left. So I'm going to go ahead and, okay, my computer's not doing what I want. Share this slide here. Because we would like to hear from you as to how we can do better. As I said earlier, I shared earlier, we are looking at what do our table talk events look like in, after the new year, as far as wanting to bring folks back together in person, and also recognizing that not everybody would like to be in person yet. So if you want to share, use the QRX code that is on the slide for our evaluation. I believe Colin is also going to share the link to it in the chat. Our next table talk, our Omaha table talk, is going to be next week, a week from today. And we're going to be talking about the topic of interfaith and atheism and having a dialogue around that topic. If you are wanting to volunteer and get involved with Inclusive Communities, Leontine Evans is our volunteer and faculty manager, and her email is on the slide as well. If you'd like to talk to her about how to volunteer with us. And as well, if you have any other questions as far as programming goes, just go ahead and email me at dominic@inclusive-communities.org. Again, I want to thank Abby for this wonderful partnership with OutNebraska, and all of our wonderful panelists for being here tonight and having this conversation. With that, we are really done. So thank you for your time, and we will see you at our next table talk.
I wondered, Dr. Amoura, can you share about your journey of, and I know we have probably about this much time to answer that question, but can you share about opening the transgender clinic and what it's like to be, a provider who's providing this very specialized care in a state where there isn't a lot of representation for doctors like yourself?
It's been an amazing and fantastic journey. It's been the most unexpected and just beautiful and rewarding privilege of my professional career. And that's been, nearly entirely because of my patients. And also it's been fun, just the unexpected support from the organization. And I say unexpected just because the other part of my professional career is in working with folks who are needing family planning, and that has been a perpetual challenge. So I'm apparently just drawn to these kinds of clinical situations, but it's where people actually need your advocacy and need the service and need your advocacy, and so it's been important for me. And it's been amazing because I get to kind of serve as a known quantity now, like among new providers that come in and they will migrate towards me, or med students that will recognize that it's like, okay, this is a safe place to go to, even just for a mentor or to find out how to get involved in this kind of work. Other new providers that join the hospital that have experience with working in trans medicine or have an interest in it, whatever, that they will migrate. And so that's just been amazingly important. And having said that, I think it's also that, thank you, John. I think it's also, it just continues to be kind of a struggle in that the advocating, there's I think advocacy fatigue can be very real, and having to go up and, you know, ask for again and again these, you know, my patients, as I was saying, like, this is why I beg the patients to speak up for themselves, because it's like the powers that be have heard me say, this isn't right, this needs to be, you know, X way or whatever. And they think it's kind of just me advocating for my own little area. And that it may or may not be that important to the patients. But I'm saying it because I've heard it straight from the patients' mouths, and I can see that it affects their outcomes and just their comfort in seeking services and all that. But anyway, it's challenging, and it's fantastic, and I am forever grateful for the patients who put up with us trying to just eke out things a little better bit by bit by bit. And we've come a long way, and still feels like there's still a long way to go. So we're working on it.
I think our whole panel was healthcare providers. Oh, Daryl, I don't know. There is a question in the chat, and I think we have like 3 minutes before 7:30. If you want to answer a little bit about ways that healthcare providers can provide affirming care for folks living with HIV, if you're still on. Great.
Yeah, great question, Audrey. I am of the belief that, honestly, again, going back to that idea of self-educating and diving in, if it's important enough, we'll do the research, right? But on the flip side of that, I really genuinely believe that we are in need of some HIV programming that is specific to medical students and physicians that are in practice. I know that they have the option of engaging in some of this continuing education at times. But again, if it is an option, and to go back to what Jay mentioned about the level of busyness and all of that, you know, the likelihood of someone necessarily choosing that as a track of information to dive into may be minimal. And so, unfortunately, I think that it would have to be something that is kind of required as far as bringing up someone with lived experience as relates to HIV, bringing up some of the data, because believe it or not, there's medical professionals that it's not just, it is a lack of education. I have run into a physician that blamed the AIDS epidemic within the Black community on the idea of the down low. It was a Black physician. B, it was so off track. It on so many levels. But I say that to say that this is someone that's in the field. This is someone that is practicing on a daily basis, that obviously has not had any required training as relates to that, has not had any updated data as relates to that, and is functioning in an antiquated mindset about the spread of HIV. And so I say that to say that, yeah, we need to really hammer down on some required education for physicians, specifically here in Nebraska. I can't speak to, I'm sure there are some other programs that exist out there that I'm just unaware of, but I think that we need something in stone here in Nebraska. And I think that that is kind of a multi-organizational project that we would do well to pull together to create.
Thanks, Daryl. It is, you managed to do that in under 3 minutes as my clock says it is 7:29. Dominic, it is now 7:30. Was there anything else before we close out our event tonight? Thank you so much for the great questions. Thank you for being with us tonight. This has been really good. Thanks to all our panelists and to our audience too. Have a good night, everybody.